So in the general scheme of things, throughout the course we've been talking about electronic health records and why we're doing them, and basically we've talked about little transactions of ordering things and recording medications and ordering labs and getting results. Once we have all this data in a large data warehouse and we can connect it from all patients all around the country, we're going to be able to do a lot more things intelligently with this data. And this is where informatics has really been promising great strides in the next 3 to 5 years for the last 35 years, let's say. But we'll see things like the computer being able to critique an action or suggest an action or plan. And so we see this right now in our simple rules that say these two drugs are interacting and maybe you should consider not ordering them, to more complex critiquing systems like usually patients that are in your situation have another drug added to try to control their hypertension. And so we can build these kind of systems, and people have demonstrated almost all of these things in small isolated pilot projects over the years, but they haven't really made it into the mainstream of the healthcare. We also hope to see a lot of post-marketing surveillance. So when we put out a new drug or a new treatment, we'll be able to watch what's happening to patients. And so, for example, you may remember the Vioxx scandal where patients were getting Vioxx, and it took a while to understand that the people that were taking the Vioxx were having an abnormal number of heart attacks. And if we had electronic health record from patients all over the country, we might have been able to discover that a little sooner. We'll also be able to do what we call comparative effectiveness research. And this is the idea that we can try to understand whether similar patients getting two drugs, we can understand which one of them has a better outcome. And so there's a lot of different medications. You may have gone to the pharmacy and gotten a generic medication, for example, and you wonder, is the generic just as good as the brand name? If we had data from a wide group of patients, we could look and see if there's any difference in the outcomes of the patients with two different drugs or even a generic version of the same drug. And then we can do categorization of patients and prediction, for example, for readmission, to try to identify patients that are at increased risk for readmission to the hospital, and hopefully we can intervene before they have to go back to the hospital. It'd be nice if we could develop some novel diagnostic and therapeutic algorithms so we could try to predict patients' oncology reactions to medications, and also to predict their outcomes, so we could help try to help them plan the future and know whether they can expect to live 5 weeks or 5 months or 5 years. And so it certainly has a whole different way of which you'd be willing to accept temporary pain and suffering for predicted longer predicted life. We could also have more real-time status measurements and surveillance, and we've talked a lot about that monitoring idea and whether we want that or not, but it could happen. And then we're going to have better patterns of data, and so we can sort of see the way things are going. We can maybe predict where patients are going, that you're gaining a little weight, it looks like your blood sugar is going up, maybe you're getting closer and closer to diabetes, and maybe the hope is that we can intervene and help people to stop and change the future. And so that's been the goal of informatics and society for a long time, is to try to make our future better.